Good morning again, and this time I have got the nerve injuries associated with gynecological surgery, quite an important talk article summarized for you, and this is all to help with your revision of MRCOG exams. I hope you'll find this useful, and if you do, don't forget to give this video a thumbs up and also subscribe to my channel if you haven't already, and leave a comment if there's anything you'd like me to create more videos on. So incidence in gynecological surgery of nerve-related injury is 1.1 to 1.9%. Compression and stretch injuries are caused by improper placement of self-retraining retractors, such as the Balfour or the Brock-Walter retractor, and in prolonged positioning of patients in stirrups. Transaction injuries, incorrectly sited, most commonly seen with incorrectly sited surgical incisions, can also happen. PFAN and still and low transverse incisions, most common incisions performed in gynecology. If these incisions extend beyond the lateral margin of the inferior rectus abdominis muscle, the lateral cutaneous branch of the iliohypogastric and the ilioinguinal nerves are liable to be injured. The pathophysiology of nerve injury, so you have your neuropraxia. Pathophysiology is external nerve compression. Prognosis is recovery within weeks to months. Type of nerve injury is axonomesis, severe compression with axon damage. Recovery takes longer, usually several months. Neurotemesis, which is nerve transection with damage to the Schwann cells. Poor prognosis without restorative surgery. So this is just a diagram showing where the ilioinguinal nerve and the iliohypogastric nerve run, and as they were saying that if your transverse incision margins go to lateral, then you're likely to damage these nerves. This diagram shows you the lumbosacral plexus, the relationship of the psoas muscle to the genitofemoral nerve. You can appreciate it here. You can also see the femoral nerve on this diagram along with the iliohypogastric and the ilioinguinal nerves. You can also see the lateral femoral cutaneous nerve and the sacral nerves S1 to S4, and also the obturator nerve. And all these nerves we're going to talk more about in detail. So yeah, we'll just move on to the next slide. This is brachial plexus. You can see whereabouts they run and which nerves are involved, and we'll also be talking about brachial plexus in detail as well. Okay, this is the most important table that you need to know for your MRCOG exams. So just highlight it, copy it, rewrite it, just do whatever it takes for you to learn this table, because there'll be a very common EMQ question where they ask you, oh, the patient had this surgery and now they're unable to adduct their thigh or flex their hip or extend their knee and so forth. So if you've learned this table well, you'll have no problems in answering that question. So femoral nerve roots are L2 to L4. Sensory function is anterior medial thigh and medial aspect of the calf. Motor function is hip flexion, adduction, and knee extension. If they're unable to climb stairs. Obturator is L2 to L4, and sensory function is upper medial thigh. The motor function is thigh adduction. Clinical presentation is minor ambulatory problems. Obturator is, sciatic nerve is L4 to S3. Sensory function is below the knee except medial foot. Motor function is hip extension, knee flexion. Clinical presentation in terms of injury is sciatica. You've got your common perineal nerve. Sensory function is lateral calf, dorsum of the foot. Motor function is dorsiflexion and eversion of the foot. And clinical presentation is a foot drop. Tibial nerve, sensory function is toes, plantar surface of the foot. Motor function is plantar flexion and inversion of the foot. Clinical presentation is cavus, deformity of the foot. Iliohypogastric nerve, Origin is the T12 to L1. Sensory function is mons, lateral, labia, upper inner thigh. Motor function is none, and sharp burning pain radiating from the incision site to mons, labia, or thigh. Ilioinguinal is T12 to L1 as well, but provides sensory function to the groin and the pubic symphysis. Again, there is sharp burning pain radiating from the incision, but to the groin and the symphysis. Pudendal nerve is S2 to S3, supplies sensory function to the perineum. Clinical presentation is perineal pain. Lateral cutaneous nerve is L2 to L3. It supplies sensory function to the anterior and the posterior lateral thigh. Pain, paresthesia, anterior, posterior, lateral thigh. Genitofemoral is L1, L2. It provides sensory function to labia and the femoral triangle. Clinical presentation is pain and paresthesia on the labia and the femoral triangle. So femoral nerve, as we said, is L2 to L4 is the nerve roots. It passes inferolateral through the psoas muscle and emerges from the lateral border. Compression of the nerve against the pelvic side wall as it emerges from the lateral border of the psoas muscle can happen, especially during abdominal hysterectomy, and that's the iatrogenic cause of injury to this nerve. Incidence is at least 11%. So quite commonly damaged nerve in gynecological surgery. Again, very common EMQ question. Ilioinguinal and iliohypogastric nerves are T12 to L1, as we said. So both nerves pass laterally through head of the psoas muscle before running diagonally along quadratus lumborum. Iliohypogastric nerve pierces external oblique aponeurosis above the superficial inguinal ring, while the ilioinguinal nerve emerges through it. Iliohypogastric sensation to the skin of gluteal and the hypogastric regions. Ilioinguinal nerve sensory innervation is to the skin overlying the groin, inner thigh, and the labia majora. Injury is commonly with suture entrapment at lateral borders of the low transverse or the phalansteal incision that extend beyond the lateral border of the rectus abdominis muscle. Neuropathy following phalansteal incision is about 3.7%. Laparoscopic and retropubic mid-urethral tape procedures may also injure this nerve. Diagnostic triad for nerve entrapment syndrome is sharp burning pain radiating from the incision site to the mons pubis, labia and thigh, paresthesia over the nerve distribution area, pain relief following administration of local anesthetic. Genitofemoral nerve runs from L1 to L2, transverses the anterior surface of the psoas and lies immediately lateral to the external iliac vessels. It divides into a genital branch which enters the deep inguinal ring and femoral branch which passes deep to the inguinal ligament within the femoral sheath. It's susceptible to injury during pelvic sidewall surgery and during removal of external iliac lymph nodes. Injury results in paresthesia over the mons pubis, labia majora, and the femoral triangle. Lateral cutaneous nerve is L2 to L3, emerges from the lateral border of the psoas. It crosses the iliac fossa anterior to the iliac muscle and enters the thigh posterior to the lateral end of the inguinal ligament. Mechanism of injury during pelvic surgery is similar to that of the femoral nerve. Paresthesia and pain in anterior and posterior lateral thigh. Myalgia, paresthesia. Obturator nerve, so anterior branches of L2 to L4 give rise to the obturator nerve and converge behind the psoas muscle. The obturator nerve then passes over the pelvic frame in front of the sacroiliac joint and behind the common iliac vessels to enter the thigh via the obturator foramen. Injured during retroperitoneal surgery, excision of endometriosis, passage of trocar through the obturator foramen, insertion of transobturator tapes, and during paravaginal defect repairs. Sensory loss is upper medial thigh and motor weakness in hip adductors. Sciatic and common perineal nerve originates from L4 to S3 nerve roots, emerges from the pelvis below the piriformis muscle, curving laterally and downward through the gluteal region. Initially, it lies midway between the posterior superior iliac spine and ischial tuberosity. Lower down in the thigh, it courses midway between the ischial tuberosity and the greater trochanter. Common perineal nerve and tibial nerve are its two derivations at the mid-thigh. Common perineal nerve, importantly, winds forward around the neck of the fibula. Sciatic and perineal nerves are commonly injured at the sciatic notch and lateral aspect of the fibular neck, respectively. Susceptible to stretch injuries from the hyperflexion of thighs in improper lithotomy positions, common perineal nerve compressed at the fibular neck in lithotomy. Sciatic nerve injury presents as sensory impairment below knee and weakness of hip extension and knee flexion. Foot drop, common perineal nerve is injured along with paresthesia over calf and dorsum of the foot. Pudendal nerve is S2 to S4, exits the pelvis initially through the greater sciatic foramen below the piriformis, runs behind the lateral third of the sacrospinous ligament and the ischial spine alongside the internal pudendal artery, and immediately re-enters the pelvis through the lesser sciatic foramen to pudendal canal, the Alcock's canal. It's susceptible to entrapment injuries during sacrospinous ligament fixation as it runs behind the lateral aspect of the sacrospinous ligament. Postoperative, gluteal, perineal, and vulval pain worsens in seated position if the nerve is damaged. Disruption of neurological pathways secondary to gynecological surgery has been postulated etiological factor for female sexual dysfunction. So brachial plexus, radial nerve, leaves the posterior compartment of the arm by winding round a spiral groove on back of the humerus. Pressure on humerus during arm positioning can result in sensory loss in the lateral 3.5 fingertips and paralysis of the wrist and finger extensors. Ulnar nerve is a medial cord and enters forearm posterior to the medial epicondyle of the humerus. Undue pressure placed on the medial aspect of the elbow during armboard positioning, sensory loss in medial 1.5 fingers, and claw hand from paralysis of the small muscles of the hand. Stretch injuries, most common mechanism of injury to the brachial plexus. Hyperabduction of the arm in lesion of upper nerve roots of brachial plexus involves nerve C5 and to C6. Arm boards are extended beyond 90 degrees from the long axis of the operating table, or when the arm unknowingly falls from the arm board during a procedure. As a result, the arm hangs by the side and is medially rotated and pronated. This is known as Erb's palsy or waiter's tip deformity. Brachial plexus injuries can happen from shoulder braces, which are used to support in the steep Trendelenger's position during surgery. The lower brachial plexus nerve root, CHT1, are stretched if the brace is positioned too laterally. This results in Klumpke's palsy with loss of function of the small muscles of the hand. Summary of the brachial plexus. So you've got your ulnar, we said CHT1, medial 1.5 fingers, small muscles of the hand, and the clinical presentation is claw hand. Radial is C5 to T1, dorsal tips of the lateral 3.5 fingers, wrist and finger extension, and the clinical presentation is wrist drop, unable to extend fingers. Erb's palsy C5, C6. Sensory function is none. Motor function is abduction of the shoulder, flexion of elbow, and supination. Clinical presentation is waiter's tip. Klumpke's palsy is origin is CHT1. Sensory function is medial arm, forearm, hand, and medial 2 fingers. Motor function is intrinsic muscles of hand. Clinical presentation is claw hand. So treatment of nerve injuries. So it's important to take a history and detailed examination to see the extent and the probable mechanism of nerve injury. Most of them will resolve spontaneously. Sensory neuropathies resolve within 5 days. Motor deficits can take up to 10 weeks to recover. Neuropathies persist beyond 1 year. Uh, Detailed neurological examinations and electromyographic studies, your EMG, are key to diagnosing a neurological deficit. A referral to neurologist is required, and EMG is useful in identifying and localizing the acute nerve injury by measuring sensory and motor nerve conduction velocity. Painful neuropathies respond to your tricyclic antidepressants and your um, GABA antagonists. Painful neuropathies rarely fail to resolve after 6 months. Then local nerve blockade or even surgical nerve excision or decompression can be tried. Motor impairment from retraction or stretch-related nerve injuries during improper patient positioning should be managed by physio so as to maintain flexibility and range of movement. Active use of muscles afflicted is generally recommended, although splinting may be protective against further injury. Uh, Complete nerve transection do not heal. These nerves may be amenable to specialist repair using micro-surgical techniques such as tension-free end-to-end anastomosis. The aim is to regain alignment of the epineural sheath and neural fascias. Repair of a transected obturator nerve has been shown to have an excellent prognosis with complete motor recovery after physiotherapy. So prevention of nerve injuries, obviously. So in pre-op, patients like your thin body habitus, ill-developed abdominal wall muscles, or narrow pelvis are more at risk of retractor blade-associated nerve injury. Further risk if operating time exceeds over 4 hours. Iatrogenic lumbosacral nerve injuries during gynecological surgery can be attributed to incorrect positioning of self-retraining retractor blades. Gold standard of correct positioning is for self-retracted blades to cradle the rectus muscle without compressing the psoas muscle underneath. Retractors, so psoas muscle is not entrapped between the blades and the pelvic side wall. The shallowest retractor blade should be used that allows for adequate exposure. Also, retractor blades that that are held by a person are monitored and apply only intermittent pressure than retractor blades that are self-retraining and can apply lots of pressure. Proper lithotomy position for the hip and knee should be used. The common peroneal nerve injury is avoided when there is padding in place between the lateral fibular heads and the stirrups. Avoid extending incision beyond the lateral margin of the rectus muscle to avoid the ilioinguinal and the iliohypogastric nerves. Shoulder braces should be positioned over the acromioclavicular joint, preventing brachial plexus injury. Arm boards should be placed at angle no further upwards than 90 degrees to avoid hyperabduction of the nerve injury. Well, thank you so much for watching this video, and if you like what you have heard and seen, then please give this video a thumbs up and also subscribe to the channel if you haven't already, and share it with your friends and colleagues who'll benefit from this as well. I hope this was a useful revision of this TOG article for you. Leave a comment of what you found the most useful from this article, and if there's anything like any other guidelines or any other TOG articles that you'd like me to summarize, then go ahead and comment down below, and I shall look at summarizing that for you. Good luck revising.